Hello, my name is Ann Nolan, and I'll be your instructor for this program. Today we're going to review Module 1, The Business of Medicine. By this time, you should have had a chance to do the work in the online program, including the reading assignment, the lectures, and the quizzes and exams. We'll start off by going through the information that was covered, and then we'll answer some quiz questions together. As you've gone through your first online module, you've gotten an idea of what coding is and what a professional medical coder does. Every time a patient receives health care, a record is created and maintained that includes observations, medical or surgical interventions, and treatment outcomes. This record includes information that the patient provides about their symptoms and medical history, the results of examinations and diagnostic tests, diagnoses, and treatment plans formulated by the providers. The medical record department and health information technicians organize and evaluate these records for completeness and accuracy. Coding is the process of translating the written or dictated medical record into a series of numeric or alphanumeric codes. We use CPT, ICD-10, and HCPCS codes to convey services and the reason they were performed. CPT codes are procedure codes. These are the codes that we use to describe what procedures or services were performed. ICD-10-CM codes are diagnosis codes. These codes explain why the service or procedure was performed. And HCPCS codes are used to identify products, services, and supplies that are not included in the CPT book, like medications administered during a visit. All of these codes are used by the biller to submit a claim to the insurance company. The codes essentially tell a story of the patient's encounter to the payer. Physician-based coders review charts and assign CPT, HCPCS, and ICD-10 codes for insurance billing. This is tied directly to the physician's reimbursement, and it's very important that the correct codes are assigned as it will affect the physician's paycheck. Hospital-based coders, on the other hand, specialize in coding for hospitals. These coders assign codes for diagnoses and procedures performed at the hospital, relying on their knowledge of disease processes. For hospital coding, ICD-10-CM and ICD-10-PCS codes are used to assign MSDRGs, which are Medicare Severity Diagnosis-related groups. This is a methodology used by Medicare for payment of inpatient hospital claims. The medical coding profession is unique and rapidly changing. Continuing education is required throughout your career as a coder in order to stay up to date with industry trends and policy changes. For example, new and revised ICD-10-CM and PCS codes are released each year on October 1st, and new and revised CPT and HCPCS codes are released January 1st. ICD-10 also releases quarterly updates, and we've seen a lot of those in the past few years with the pandemic and the new codes for COVID and its related procedures and supplies. As a coder, you will be responsible for keeping up to date with new and revised codes and applying them to your work. It's very important to remain flexible and to understand that as our industry changes, we too must evolve and grow. Ultimately, your success as a coder will depend on how well you can adapt to change and continue to learn. In my personal experience, the people who do the very best in this profession are the ones who love to learn and who will go the extra mile to keep up to date with the changes in the industry. As the use of EHRs continues to expand, we also see our responsibilities as coders growing. Likely, you'll be using an EHR to do your daily work, and sometimes you may find yourself working in more than one EHR in any given day, depending on your role. Coders may contribute to the development and maintenance of EHRs under certain circumstances, and some coders may find themselves in more of an auditing role with the emergence of computer-assisted coding built into some of the EHRs. Anatomy and medical terminology will need to be mastered, as you'll need to have a firm understanding of the disease processes you are coding. ICD-10-CM codes are highly detailed, and the coder must also be very detail-oriented in order to select the correct code. While the PMCC material covers basic anatomy and physiology, we will cover some expanded anatomy and terminology. It's important to understand that developing a deep understanding of anatomy and terminology takes time. As you are learning and as you eventually begin working as a coder, you'll find yourself looking up disease processes and procedures in order to gain a better understanding of what you're coding. This is necessary, and you'll find that with each chart that you code, you'll get a little better at understanding the bigger picture. Working as a professional coder in a physician's office, you will mostly work with Part B Medicare or Part C Med Advantage. Let's take some time to discuss the medical record now. The patient's medical record contains pertinent facts and observations about a patient's health. The medical record serves three main purposes. It provides continuity of care between providers, it helps with claim review and payment, and it can also serve as a legal document. Continuity of care between providers means that the information documented in the medical record by one provider will serve to help any subsequent providers by detailing important information about the patient's medical conditions or treatments. Facilitating claims review and payment means that the information in the record should support the CPT and ICD-10 codes being submitted to the payer. By having proper documentation, claims get paid more efficiently. And sometimes a medical record will serve as a legal document, for example, in a medical malpractice case. As coders, we're responsible for understanding the information in the medical record. This is the information that we will use to assign codes for the patient's services. One type of documentation that we'll see in the medical record is evaluation and management notes. These are notes for patients being seen in the office or another setting. Most E&M notes are in a general standard format, as seen here. We call this a SOAP note. S stands for subjective, and this is the patient's own statement about their health, including their symptoms and their history. O is for objective, and these are the objective findings and observations by the provider. A is for assessment, and this is the conclusion or the diagnostic statement made by the provider. And finally, P is for plan, which is the course of action developed by the provider. While E&M notes do not have to follow the SOAP format, most will be following a layout similar to the one here. Here's an example of an operative report. This is the documentation that you will see when you code a procedure or a surgery. Most operative reports have a header and a body. The header usually will include the date and time of the procedure, the names of the surgeon, co-surgeon, and/or assistant surgeon, the type of the anesthesia and the provider who performed the anesthesia, the preoperative and postoperative diagnoses, the name of the procedure performed, and any complications. We'll look at an operative note in more detail later in the course. Medical necessity. What does that mean? Just because there is a fee associated with the code, that doesn't mean that the provider will be reimbursed. In order for a payer to reimburse a service, they must believe that it's medically necessary. It isn't always easy to define medical necessity, and oftentimes different payers will have different interpretations. Here's the CMS definition of medical necessity. According to CMS, the definition of medical necessity is services or supplies that are proper and needed for the diagnosis or treatment of your medical condition, that are provided for the diagnosis, direct care, and treatment of your medical condition, that meet the standards of good medical practice in your local area, and that are not mainly for the convenience of you or your doctor. It's important to note that CMS has the power under the Social Security Act to determine if a service is reasonable and necessary. If Medicare or another payer determines that the service was not medically necessary and a payment has been made, the payer will demand that that money be refunded with interest. In addition, if it's determined that there is a pattern for billing for services that were not medically necessary, and if it's determined that the physician knew that it was not medically necessary, then the physician may face criminal charges as well as monetary penalties. Ultimately, it's up to the provider to document the medical necessity, but we as coders need to ensure that we're coding accurately based on the documentation available and to the highest degree of specificity. Under the Social Security Act, there are regulations that govern medical necessity. CMS develops policies based on items or services that are covered by the Act. CMS is not allowed to cover any items or services unless they have been put through the legal requirements. National Coverage Determinations, or NCDs, describe whether specific medical items, services, treatments, procedures, or technologies can be paid under Medicare. Each local MAC, or medical administrative carrier, is then responsible for interpreting those national policies into regional policies. These are called local coverage determinations, or LCDs. LCDs only have jurisdiction within their regional area. For instance, where I'm located in Idaho, the regional MAC is Noridian, so only Noridian LCDs are applicable to claims generated in this MAC jurisdiction. The MACs may also define what codes are needed for coverage in a related billing and coding article. Here we have an LCD for routine foot care from Novitas Solutions, which is another CMS contractor. The LCD includes information on the national coverage policy that the LCD is attached to. So here we see that this local coverage determination is related to 3 different citations in the CMS Internet-Only Manual and 4 different references in the Social Security Act. This section of the LCD explains when the service is indicated or considered medically necessary. In this snapshot, we're only seeing a portion of the indications. So under indications, it first says to see the IOM publication 100-02, and then it gives some additional guidance. We read on and we see that certain foot care services are considered to be components of routine foot care and are not reportable to CMS. These include cutting or removal of corns and calluses, clipping and caring for toenails, removing and tending to keratomas, and simple treatments like removal of plantar warts. We're told that while CMS generally does not cover these routine foot services, there are exceptions to when they can be billed, such as those listed in the Internet-Only Manual and the ones referenced in the snapshot here. For example, for patients with certain systemic conditions like peripheral vascular disease and Raynaud's phenomenon. Here's a section on coverage limitations. We would have to read through these to see if any of them apply to the patient that we were coding for. Also within the LCD, there will be a link to a billing and coding article. These articles can be found on the MAC's website, and they contain the specific CPT, ICD-10-CM, bill type, and revenue codes that are covered under the LCD. This section of the LCD describes the specific CPT codes found in the associated billing and coding article for this policy. So we see that CPT codes 11055, 11056, 11057, etc. are the CPT codes that this article pertains to. Finally, the billing and coding article will list the ICD-10 codes that support medical necessity for the given service or procedure covered in the LCD. This is an example, and this is not a complete list. So we see that here, a diagnosis of Charcot's arthropathy, HIV, or tinea unguum, which is a nail fungus, would be qualifying diagnoses for these procedures. If you're providing this service and the patient's diagnosis does not support the medical necessity requirements per the particular policy, your practice would be responsible for obtaining an advance beneficiary notice, or an ABN. Practices should check policies quarterly to maintain compliance. Other carriers may or may not recognize ABN forms, and careful research is needed to determine the use outside of Medicare. In some instances, health plan contracts may have a hold harmless clause found within the language that prohibits the billing to the patient for anything other than the copays or deductibles. So what exactly is an ABN? An ABN, or Advanced Beneficiary Notice, is a standardized form that explains to the patient why Medicare may deny the particular service or procedure. Additionally, an ABN protects the provider's financial interest by creating a paper trail that CMS requires before a provider can bill the patient for payment if Medicare denies coverage for the stated service or procedure. Here is a snapshot of what an ABN looks like. Providers are responsible for obtaining an ABN prior to providing the service or item to a beneficiary. The form must be filled out in its entirety, as well as the cost to the patient and the reason why Medicare may deny the service. Only the approved form CMS R131 is valid, and the forms may not be altered in any way other than to put the practice information in the header area. Coders will not be responsible for obtaining these forms. However, you will need to know when an ABN is required and what to look for when reviewing one. The Office of the Inspector General, or OIG, acknowledges that patient care is and should be the first priority of a physician's practice. However, a practice's focus on patient care can be enhanced by the adoption of a voluntary compliance program. A voluntary compliance program provides physician practices with many benefits, including faster and more accurate payment of claims, diminished change of payer audits, and sending a signal to the employees that compliance is a priority. Although a compliance plan is currently voluntary, the Patient Protection and Affordable Care Act of 2010 will require that physicians who treat Medicare and Medicaid beneficiaries establish a compliance plan. The effective date will be set by future legislation. Here's a snapshot of the OIG Compliance Plan program for individual and small group physician practices. This is to serve as guidance for physician practices to create their own. There are 7 key actions to a successful compliance program, and you're going to want to memorize these because they will likely be on the certification exam. These include: conduct internal monitoring and auditing through the performance of periodic audits, implement compliance and practice standards through the development of written standards and procedures, designate a compliance officer to monitor compliance efforts and enforce practice standards, conduct appropriate training and education on practice standards and procedures, respond appropriately to detect violations through investigation of allegations and the disclosure of incidents to appropriate government entities, develop open lines of communication with staff meetings, newsletters, and other lines of communication, and enforce disciplinary standards through well-publicized guidelines. Another report published by the OIG is the OIG Work Plan. The OIG Work Plan is updated monthly on the OIG website. It outlines the OIG's priorities for the fiscal year ahead. A medical coder should be aware of the OIG Work Plan to know where the OIG's focus is going to be in the coming year. Here is a snapshot from the OIG's Active Work Plan. This information identifies that there will be a review of spinal pain management services to determine if the Medicare payments complied with federal requirements. If your position includes coding for these services, you'd want to pay extra close attention to these claims to ensure that they're being coded in alignment with CMS policies. Thank you, and see you next lesson.